Chiropractic Roentnology. But why use the term Roentnology in chiropractic clinical imaging? Well, some studies say that there's a large group of coincidences involving that terminology, and one of them is that in the same year, when in November 1895, on Friday, Willem Conrad Röntgen, director of the Physical Institute of the University of Würzburg, discovered a new light which he called X-ray. And in the same year, in October, when Didi Palmer discovered the science and the art of and the philosophy of chiropractic, when he performed his first adjustment in a Harvey Lillard, the first chiropractic patient. But it was not just this, because chiropractic were very pioneer in the clinical use of X-ray. And some historians say that chiropractic in Palmer School of Chiropractic had the second X-ray machine in the Western world. The X-ray were discovered accidentally when trying to duplicate an experiment by physicist Philip Leonard using the cathode ray and blooming. This discovery earned Whelan the first Nobel Prize in Physics in 91, which borrowed Leonard until his death, and gave the name of Wilhelm Conrad Röntgen to the exam of X-ray in Germany. And then when order an X-ray, you order in German Röntgenaufnahme. The chiropractic use of X-ray began between 98 and 1910. The first machine purchased by Palmer School of Chiropractic was the Scheidel Western X-ray Coil Company of Chicago. It was not initially accepted by most professionals, including the professors inside the philosophy chairs in the Palmer School of Chiropractic, one of them, Joy Loban. And the initiation of radiology, even with a lot of conflicts, bring a lot of innovation for chiropractic. His initiation, however, promoted the evolution of the chiropractic care. A number of special techniques have been developed from cervical spinography, like Burr, Petitbon, and Gonstead method also. And the development of radiology bring a lot of conflict, how I said, and a lot of vanity dispute that is very normal and often in chiropractic area. Why chiropractic needed X-ray in 1910 when it had not in 1895, the year of the discovery of chiropractic? That is what Joy Loban said. And then, to answer this question, we can say to evaluate better pathologies that contraindicate the employment of certain chiropractic techniques. I will explain. In Gonstead, for example, when you have some listing in the sacrum and BP, for example, BP sacrum, we have to see well where you adjust and how to put the contact in the L5 vertebra to a luft L5 vertebra, because if there is a BP on the sacrum, it's possible to have L5 more anteriorly, and you don't need to do a pitch weight technique on this area, because the patient can experience a lot of pain, and sometimes you can change the possibility of the technique and choose another one to have a better outcome and not so much discomfort to the patient. And sometimes we have spondylolisthesis, and spondylolisthesis also may be stable, and you can choose another technique, even is the technique is not contraindicated to chiropractic. It's not like a non-manipulatable vertebra, but you can change and use the right technique, the more easy, more comfortable, more safe technique to have a better outcome with a soft approach to the treatment in chiropractic. And then this is a very interesting possibility. And also assess the presence of non-manipulable vertebra or joints. And this is very fundamental for safety, for promoting health to the patients. And this is now is one of the biggest tenets in radiology for chiropractic. To perform radiologic control, such as in the case of scoliosis in growing children, guide the treatment plan in chiropractic. Some techniques like chiropractic biophysics use X-ray a lot, treating the curvatures of the spine. And also, spinography is useful to assist in the joint adjustment, providing useful information associated with other evaluative aspects in chiropractic. Like Constant do, he don't do only X-ray. He did five-step for diagnosis, and X-ray is only one of them. And even Gonstead said that you cannot give the diagnosis of a solution or dysfunction only by X-ray. It's just one of five steps in the Gonstead evaluation. And then we have here two exponents in X-ray inside Palmer College. One is James McInnes, Spinography in 1910, and the other was Ernest Thompson, first chair of the Spinography department in the Palmer School of Chiropractic. Under Palmer's direction, I mean Bartlett Joshua Palmer, the son, the called developer of chiropractic, the emphasis of radiological interpretation was first focused on biomechanics finding with the use of spinography. BJ stated, a chiropractor must be able to recognize abnormal conditions of the spine. And then the Department of Palmer School of Chiropractic for 1938 to 1966 advocated the need for chiropractors to x-ray the site of patients' complaint, not just the spine, and interpret all radiographs for abnormalities such as pathologies. After the lost years of chiropractic, when Didi Palmer, the discoverer of chiropractic, was almost put under arrest due to the practice in medicine that was blamed for many osteopaths and other doctors. And the Didi Palmer need to sell this school, Palmer School of Chiropractic, his part, the part of the father, Didi Palmer, to the son, Bartlett Joshua Palmer. And then BJ had to be with to take control all of Palmer School of Chiropractic after 96, and then may have rested maybe rested some conflicts in with other professors and teachers in chiropractic. This is Joy Loban, one of the most brilliant teachers in Palmer School of Chiropractic. He was the catedраtic in chiropractic philosophy in Palmer School of Chiropractic. And when BJ, in the verge of 1908 or 1910, started with the X-ray introduction in chiropractic, Joy Loban was very against that, and this gave a lot of problem in Palmer because he convinced many professors in Palmer to leave the Palmer School of Chiropractic and start another faculty, another course, another school of chiropractic. One of them was Universal Chiropractic College, that was founded by Joy Luban. And then this make Palmer School of Chiropractic very pioneer, not only in chiropractic but in all the branches of health science, including pioneer in medicine, considering the use of X-ray. But in few years, many schools that condemned the department about the use of X-ray with chiropractic start to changing opinion and going toward radiology also. That's what happened in 1917 when the National College of Chiropractic in Chicago began using the teaching X-ray in the others courses included also disciplines like the Pacific Chiropractic College in 1919, Oregon wrote, spinography is very essential thing for chiropractic to know. Also, the Eclectic College of Los Angeles added spinography in that same year. In 1921, that guy, Joy Loban, that was completely against and abandoned Palmer by the start of X-ray in 1910, changed completely his mind, and in his proper university, in his proper, it was not really university, it was just a course. This was a school of chiropractic, it's not exactly a university system in that time, in the beginning, very beginning of chiropractic. In 1921, Universal College began offering X-ray in the undergraduate and postgraduate programs, and they say for those who desire to feed themselves for this specialistic work. And then also happened with other courses and schools of chiropractic. Pacific College, after that, considered X-ray to be compulsory and an obligation in curricula, as did several other chiropractic university and some postgraduate programs for to fit the other chiropractors that already had the diploma in chiropractic, started to complement the formation of this chiropractic in radiology. In the beginning, between 1910 and 1924, the spinography was realized in the position of supine. But in 1924, that one that wanted nothing about X-ray, that was opposed about X-ray, became a pioneer in X-ray because he announced the first use of standing X-ray to analyze the spine and lumbar and pelvis, and that was very incredible because it's a very big mind changing when that one that was very opposed to X-ray become another pioneer in X-ray, then start another type of analysis for chiropractic in starting to do in standing position. In 1986, radiology became a specialty of chiropractic, and the title of chiropractic radiologist was created. And then in the United States, chiropractors can do 3 years after the chiropractor's degree, the DC degree, and more 3 years of residence or program of residence. He can be diplomated as a radiologist, a chiropractic radiologist, and can do musculoskeletal exams and have a proper clinic of like a consultant, not adjusting anymore, just doing X-rays, and also can write laudas about musculoskeletal systems diagnosis, not just doing the exam like in Brazil. There's technicians in Brazil, but the chiropractors that have this special title can also give diagnosis about the X-ray and some other exams in United States. It's a very special title for uh, chiropractors to do very uh, independent uh, chiropractic act in radiology, and this make the chiropractic go very on top in the United States, and some physicians studied in a lot of um, chiropractors imaging books, and this is very amazing because a lot of knowledge built for the branch of radiology built by chiropractors. And this is an example of body position device used in interpretation of X-ray for subluxation analysis. And these make a lot of influence in chiropractic during the next decades, and get a lot of influence in the development of chiropractic clinical philosophy. And then many specific devices for chiropractic radiology have been developed, such as cervical analysis instruments, gross stick models, and others, like Blair and Gonstead, a lot of different traces in spinography, and all of this is considered in chiropractic different patterns like Huttis draws and Logan method, different types of spinography, and also for upper cervical, for example, for hole-in-one, Ohio. And the insertion of X-ray in chiropractic promoted a rebellion, and this rebellion was a very interesting, very big landmark in Palmer School of Chiropractic that was led off by Joy Loban, that one that after some years, uh, after start a new uh, chiropractic college, the Universal College, changed his mind and started to do X-ray too, and being a pioneer when he did the first analysis of standing X-ray and to chiropractic, and then a lot of vanity and conflicts, and these problems goes in the chiropractic professionals till nowadays. Is unfortunately this is true. And then when we go to spinography, we must understand that spinography is not only in chiropractic, there is in medicine also. When we classify some situations, we have to use in orthopedics, for example, in neurologists, for example, some spinography in some cases to let's think about changes in the base of school. Like here, we see the McRae line, and we have other Chamberlain's line, McGregor's line, and we have these lines to be safe that's nothing getting wrong with the patient. If you have a diagnosis like rheumatoid arthritis, node Chiari, and Marfan syndrome, and others, and these situations are very well analyzed and diagnosed by the spinography lines, like McRae's line, for example. We cannot admit that the odontoid crossed this line because it's very severe situation, and this is alarm sign for the doctors to do another stuff with these patients. And something else we can understand that spinography is very important in medicine also, in orthopedics, and it's not just for chiropractic. And chiropractors also needs to know all this type of spinography, not only spinography for Gonstead, and a lot of chiropractors don't use the Gonstead systems, but need to know some concepts about clinical and orthopedical spinography, because there's a lot of conditions that we cannot adjust a patient without have a good X-ray analysis, Röntgenaufnahme analysis. And then it's very important that X-ray is important not just for treatment, but to see something wrong with the patient, something that cannot allow the treatment, the adjusting treatment, the manipulative treatment, and then there is also inside of X-ray analysis and imaging have spinography that is different from the Gonstead, the Logan spinography that is focused on adjusting. There's in spinography focus on prevention and clinical controlling. And then, such as this situation that we have to see the space here between the odontoid process and the anterior arc of atlas. And this space is, we have a length here that we can allow and understand it's possible and it's normal. When the patient goes to the flexion, this space get bigger and go to extension. This distance get smaller, and then we can evaluate the patient sometimes in functional X-ray and put this patient on a flexion. A little bit of laser here. Put the patient in flexion and put the patient in extension and see what's going on with this space. This space is anterior space between the odontoid process or axis vertebra and the anterior arc of atlas. And this space is very important to evaluate of instability, evaluation of instability, atlantoaxial instability. And this is very important. We can see instability here in dynamic or functional X-ray. Like here we have also the distance, the posterior atlantoaxial interval, the posterior, and here is the anterior. We have also here, let me see if I have here, don't have here now, but we also have this space when we see the transoral and open mouth X-ray in AP view. And this we have to take care also in the patients if there is a balance on these spaces, because if no balance, maybe some fractures and some and other serious stuff we have to take care in our patients. And then just to take understand to have experience here, we have the McRae line, Chamberlain line, McGregor's line, the Ranawat, Redland, John Peterson, and all these lines are used to instability, to see changes in the skull, changes, malformations, modifications in the basal skull, the basilar angles and basilar structure. For example, this line here must be a slope from behind to anterior, going up and never should go down. And when this line, McRae line, go down, is really a problem. And then there's a lot of hints and some role that we can use these lines. And it's not the focus now, but should be in another moment when you have a special radiology class about chiropractic, and be very, very interesting. It's very good for the clinical practice to have a safer practice, to understand these concepts of spinography for not to detect solution, just but to detect problems and anisomelia and skull basilar changes is very important. And there's another type of spinographies that's in chiropractic, inside the chiropractic. I say clinical spinography, the medical orthopedic spinography, hole in one, for hole in one, the HIO, upper cervical, palmar upper cervical specific, radiographic series, the Blair technique is very different spinography, type of spinography. Ghosted lines, Huttis, Drosky, and Logan, to see the distortion theories, distortions of the body, that because um, Logan and follow Logan is not Loban, is different guys. Loban was a pupil of Willard Carver that studied distortions, the 10 Carver's distortions. And these distortions are very interesting to do a very good diagnosis. Logan was the pupil of Willard Carver and was the first to one of the first to evaluate the patient in the standing position. Most of chiropractic in the early beginning prefer to evaluate the patient in the prone position, and Logan start to understand and study better the role of posture, the evaluation in a standing position, and understanding that the posture, if you can see different things when you evaluate the patient in standing, sitting, or prone position. It's very interesting, the Logan method and concepts of Logan, because it give a lot of information and mindset for the clinical issue and the clinical treatments. Well, for example, this is the stereoscopic X-ray for Blair, because Blair studied a lot the atlas, occiput, and axis, and perceived there was a lot of changes, anisomelia, in English, I guess is anisomelia in Portuguese, and these changes are like we cannot say this is congenital, but morphological changes, not congenital disease in the bone. I'm not talking about that. I'm talking about anatomic change. That is considered normal, because when you have more anatomic change than the standard equality in standard quality, the normal thing is the variation, and that's why we are different. One in the same ethnic, between German, Portuguese, African, there is a lot of change inside these groups. And if you examine, like Blair did, many X-rays in the standard spinography of the other methods of upper cervical analysis, he found a different way to analyze. It's called stereoscopic X-ray, and these consider the changes that the most of people have in the structure that is normal, is congenital. And then anisomelia is something that we have to understand. Dr. Blair developed his approach to upper cervical. He said in his paper, a synopsis of the Blair upper cervical spinography research, November 1964, after studying hundreds of cranioatlantoaxial spinograph and specimens from B.J. Palmer osteological collection. He said that most of the people have anisomelia, is difference in the structure, and this is a challenge for spinography. And then we have to take, and he got a way to skip this problem by stereoscopic X-ray. But we have some hints in the course of our practice that we can use to detect anisomelia, and we talk after about this. And then we start now about spinography in the Gonstead method. Well, I consider the pelvic spinography in Gonstead method easy. It's not something difficult, but more difficult is understand how does the spinography fit with the clinical practice, if another and with the other levels of evaluation, because we have visualization, we have nervoscope readings, and we also can do it in the sacrum and sacroiliac joint. We have static palpation. After that, we have motion palpations and some tests. And after, we have this spinography. And I see many doctors and students in several seminars thinking that we need to start in spinography, and this uses a PI, and spinography I need to adjust PI. And there's a lot of rules to follow, and the main rule is that X-ray is not the top of the pyramid, is not the decision point. X-ray is the five step we can see in the to the side adjust. But it's very good because there is a very good law for it. Because if you have the dysfunction, this dysfunction can be seen better in a pattern of kinesiopathology. It's a pattern of kinesiopathology on X-ray, because uh, doesn't mean that an iliac bone on the right is supposedly PI, that it's really clinically PI in a patient. It's very, very important. And doesn't mean that this is a primary dysfunction to adjust and will solve everything in the patient. And then it's very important, the anamnesis phase is very important, the restriction. If you have no restriction, no subluxation. And if you have restriction, maybe this is not the subluxation. Maybe this is just a compensation. And then we start from the point. If there is a possibility of subluxation, if you think there is a subluxation in a place, this place may be hypomobile, restricted. This is very important. And then the palpation, motion palpation, static palpation is very important together with the nervoscope readings. Yes, and most most important is what the patient tells to you. This is clinical management. Some guys direct their self and only in the status of spinography or other phase of the analysis in the Gonstead, but don't they forget that the Gonstead in his teachings uh, didn't say that only one thing, or to go so to be specific must be attention, must have a lot of attention in the everything, yeah, not only in one step or other. And some guys have a preferred step in constant analysis. I see this in many cases. And then let's think about how we are learning the process. Let's think about in the paradigm of in the universe of spinography, and let's direct ourselves in pelvis. And then the first phase is to have points of reference, and this is, let's see, this is a laser. Okay, it's working. And this is I cannot write here, but I will explain, and I have a guide to you about all this methodology. And the first thing I want to teach, I want to explain to you, that we have reference points. And one of the most important reference points is the line of in where we have the upper part of the femoral head. Yes, is a point of the femoral head. And each femoral head you must do a point like this. Let's try to change here for the pen. Then I must make a point here and a point here. And some guys do like trying to bend. I cannot do, yes, I don't have a roll here. That's why it's racket line. Some guys just connect one point to other. It's not the best thing to do. You must have a point and do is horizontally, and then you sometimes you feel a difference. Let's try to erase this. Um, Eraser. Sometimes we have a difference because one line, I guess this is higher. One line is higher than another, something like this. And then you have to build a line horizontally, and then you perceive there is a difference between one and other femoral head. And this is the femoral head line. And sometimes the femoral head line will have a difference, and we must know how much is this difference. And also, let's just erase this. And also, we have to do another lines, and we lines, and the other lines also start with a point. It's here. The, the top of the pelvis on one side, and the top of the pelvis in the other, and the bottom also. And you see, again, we don't never do such a thing to try to connect one point to the other. We must just know where it is, because we never connect this to this and neither this to this. It's not good. It's a point for mistake. And we must to understand the distance between this part and this part. And we have also a special rule for this. Like the same, we do the more lateral part of, sorry, more lateral part of the pelvis and the ilium, here and here. And also we have a shadow here that we have one bone over the other because they fit one to each other diagonally. And this is the more medial part of the pelvis on one side, and this in the other side. And we also will connect the larger point, the more lateral point, with the more medial point. And then the same will be here. Not this, never this point with this point, never like this, never, no. Okay, this is very important, because we must know this distance here. We must know this distance here. We must know this distance here. And that's why we build points. And the same will happen, like all these points here, point 15, like here. Point 15 is this area, and I will mark this like to see an horizontal line in sacrum and see what's going on with the sacrum, if it's bending from one side or other. And also, we can project the margin of the sacrum, like this, S2, and like this, the more lateral part of the wing of the sacrum. And we have this difference, this distance to know. And all this information is important. The lateral wing must be obtained. This distance must be obtained, and the height of the ilium also, but not from one point to other, like here, in a line that can build the more biggest area. Okay, and then when we build all this line, we have a progression, and like this femoral head line, and this is a very good information. We will see more. This is the difference, and I must know how much is this, and then I can have a program or I can use a rule here to know how much is this difference, because this distance have some involvement relation with the dysfunction in one pelvis or another. And also we take with the roll, we take this distance that is 223, and this distance here is 226, and then this is higher. This is higher, and if it's higher, it's pi. Tends to be pi, and this is a yes. But what is pi and what is yes? Depends on what? Depends on some roles. One of the roles is the position of the body of L5, but it's not just this. And then we have here the lateral, let's see, just for a point here, laser point. And this width here, letter A, and this width here, letter B. When we have an external iliac, the lateral dimension appears to be large due to the external weight bridge. In internal iliac B, the lateral dimension appears to be smaller due to the internal weight bridge. And then it's the same rule we observe here. When the higher ilium should be, we must consider from the top to the bottom and the top. And what we have a bigger distance will be the PI, and the smaller distance will be the AS. But you must consider also other rules like restriction. It's very important. And then when I say there about the restriction, to know if this, for example, if this is like this is, for example, IN. This dimension is 115, and this dimension is 106. I must consider if there is restriction here. And then, what more? What I should adjust? The IN or EX? We must consider also the primary dysfunction, and then one of the criteria is the rotation of L5. But look at this, it's not a position. This rotation is not a brick out of the wall. We must consider that there is a restriction of motion here when I say this. And then this is very important to keep the technique and the concepts of concept to the knowledge of nowadays. We must be all the time up to date. Here we see femoral headline that in this book they connected one point to the other. I don't like this because it would be better to make a horizontal line like this. This shows us that this tilting to the side, but this is not so good because we need to have a horizontal line to perceive the difference between this femoral head and this femoral head, because this difference we have, this distance is can be related with the dysfunction on the ilium. This is very important, and there's a role about this. I'll explain. And then we can build and dysfunction like IN or EX, PI or AS, and we can have also composed listed like this, PI EX, because this is higher, because there's a bigger length, like this is a bigger length, this is 246 from height, and also we have a distance here that is considered also, and this distance is higher than this distance, and then This is IN and this will be EX. And then this is the primary side and the side of the listing because of the rotation of L5. The, and this rotation is not a position, it's a pattern of restriction, like this. And we have a number here, like this, and like this, and this. And how do we build this number? How do we get this number? We get this number because when we take this distance, like this, and like this, we have a difference between the right and the left side. And this difference is, for PI is 2. And this difference for EX or IN, the difference is, I guess, is 1 here, is 1. Yes. And then we can understand that PI2 EX1 is primary because when we write here this code, this listing, we are indicating that this is the primary. And if it was this side, the primary, it would be AS, IN, and also would be 2 and 1, respectively. Okay, and that's why I put this in image here, because why we consider the fixation, the restriction of motion of L5, because there are these ligaments, iliolumbar ligaments, that are connected mainly with L5, some fiber with L4, that will give the influence between the primary dysfunction. And this, what will impact more for the rotation of L5? The right or the left side? And then this is the primary. And this is the same. This is 226, 226, and this is level. This is normal, but we must see. And then I don't need to adjust this patient. No, we must see the IN and the X. And we must take this distance also. And then sometimes I have a pure distance of IN, EX. And like this, the same thing here. And then I need to just see what I guess this is IN. And if it is IM, I will just only IM here. Like this is EX1, this is ASIN. And one thing that is very important, that the composite listings may be AS. I will write here. Find a pen here. You can have ASEN, you can have AS EX. You can have also PIEX and PIIN. Something is very important, that when you have any of these dysfunctions, that may be EX, maybe like here, let me see here, IN, yeah, any of these listings that may be here, like here is equal. When you have, for example, this is PI. All these listings here, like EX, IN, all of them have an impact in the femoral headline here. F, age, femoral headline. What kind of impact? We must consider that the patient is on a standing position. When you have a PI, EX, AS, IN, we have a role called the role of dysfunction. The role of this function is PI have the same effect in the femoral head, the same impact in femoral head like EX. So PI is EX equal EX effect. PI is different IN effect. AS is equal to IN effect in femoral head line, and AS is different to EX dysfunction in femoral head line. In this situation, this line, in the same side, all the time in the same side. Well, how can I say? This is called marriage listing, and this is called divorce listings. So this is marriage, this is divorce. This is divorced. This is marriage and this is divorced. Divorce listing. Okay? Do it better. Divorce listing. Why divorce? Divorce because we have the different impact in femoral head. Femoral head line. This femoral head line here. This femoral head line. Okay? What impact? We have the role. We have the role of dysfunction, and each 5 millimeters, each 5 millimeters, each 5, we have 2 millimeters, and diminish for PI or EX. Every time we have a dysfunction of 5 millimeters in PI or EX, doesn't matter. If you have 5 PI and more 5 EX, you have 10 in marriage listen, and then we have 4 in diminish the femoral head line at the same side. The impact will be diminish the femoral head in same side. When you have AS or IN, this will make the femoral head go up 2 millimeters. The against. Okay, this is the role of dysfunction, and we also have the role of correction. If you correct the PI or EX 5 millimeters, will make it go up. The femoral head line will go up 2 millimeters, and this is the against. If you correct AS or IN, 5 millimeters will go down 2 millimeters. This is a role. This is very important to know, because that's why we know the difference here. We must know the difference here. This is the point. Oh, this is the point here, and this is the point here. And there is a difference here. And we need to know this difference, because if it's 2 millimeters, there is a dysfunction that are giving this distance in femoral head line, and you must discover. And if treats getting better, if you treat well, treat right, you'll get it better. And then that's why I say it's important to have a point here and build a line in the same horizontal line, and to have data, this data of the distance of the femoral head on the right and the right and the left, and don't just connect one point to another. This is not good. Okay. And then you already know what is 6 is this function, is the difference between the IN side and the EX side. And if you have 6, you have at least 2 millimeters of impact in femoral headline. And this is what makes in femoral headline. We'll make it, IN makes the femoral headline go up. What you see here, IN make it up. And then we must know how much is up to confirm. And then if there is no logic on this number, maybe there's anisomelia. Anisomelia. If the count don't match. Okay. And then I guess it's enough for office. This is just a review, and yeah, we must study in face to face. Then that's what I explained to you. This row, figure 51. IN 5, raise the femoral head 2 millimeters. Here, 2 millimeters because it's 5. And the IN go make it go up. The dysfunction. If correct 5, go down, make it go down. This is the role of dysfunction, is put it up in case of IN. If it was EX, would be put it down. And then here is the PI. PI dysfunction, put the femoral head down. And then you have 2 millimeters. If you correct PI in 5 millimeters, will be level, will be balanced with the other. Okay? This we must consider in composite. If it is ASIN, you add the information. If you have AS5 and IM5, you have to make a sum 5 plus 5. And then this is 10, this is 4 millimeters. And this 4 millimeter will impact in the femoral headline in the same side, that make it up in the same side. And then here we have AS10, EX5. This is a divorce distance. In the AS10, ES5, we have 10 less 5 is 2 millimeters. And then the femoral head will be just in this function, just 2 millimeters, yeah, and in change against the other. It's very important to know it. And then this is the sacrum spinography. We have here to make to build a horizontal plane line of sacrum. Here is the femoral headline. We have here also a line that we build here in the margin of sacrum. We build another here, and we can also see what's happening with the apex of the sacrum, if it's on the right or in the left. And then this is an example of the horizontal line going down. This is a posterior inferior left. And this, how can I know if the sacrum is posterior? Is not difficult, because there is a very nice illustration here, and they show what is small and what is bigger distance. And then we consider the tubercle here of S1 or S2, maybe it's better S2, and until the margin, lateral margin of the sacrum. And then when you feel that this is, you perceive and you count, this is The smaller distance, this is anterior, and this is posterior because it's bigger distance. And then why? Because it's a shadow. It's not the bone twisted itself. It's a shadow projected on by the X-ray. And when the sacrum is rotated anteriorward, and then the distance here from the lateral margin to the midline will be shorter, and here the distance will be bigger. That's why I show here in the another illustration. Okay, and also we can observe and correlate the sacral foramina and build lines and see in these lines if there is a malformation in sacrum. I guess for sacrum and for pelvis is enough. And we can also see here about spondylolisthesis, and we do the Ullmann's line, and then we can perceive here how much it's dislocated anteriorward to spondylolisthesis classification of Meierdings that divide the surfaces in 25 each degree here, and then if in this case it's just 25 percent, and then this is the grade 1. And then we go to cervical. Well, before I start with the Gonstead lines in spinography, I'd like to talk before about some very important orthopedic spinography lines. One of them is Chamberlain's lines. The Chamberlain's line is built in a special point called opistheon. This is in the internal and posterior verge of the magnum foramen, and this will connect with a line here in the hard palate. And this line is very important reference because in some pathology, maybe some indicative of dysfunction, how the reference is the tip of the odontoid should not extend more than 7 millimeters above this line. And if this happen, may be related with some acquired or congenital softening disorder like Paget disease, fibrous dysplasia, and others. The basilar angle. This angle is constructed by two lines. The first will come from the anterior board of magnum foramen and will be connected with the center of sella turcica. And the other will be the connection of the center of sella turcica and the nasum, this line here. And this angle will have a reference, of course, and the reference will be 152 at maximum, and this angle should not exceed this measure, with the minimum value of 137 degrees. And if the reference do not match inside this reference pattern, may be related disorder with congenital or acquired bone softening disease like Paget disease, fibrous dysplasia, and also may be related with basilar invagination, also called basilar impression, also secondary to bone deformity or acquired bone softening disease. And this is very important because it's a situation that we cannot manipulate this patient. And sometimes these patients appears in our office because it's just in the beginning of the condition. Another line here is very important because this is a line for security, for to evaluation of the patient, to control and follow up in some disorders like rheumatoid arthritis and the same softening bone disorders, congenital or acquired disorders of softening bone. But also is a line that we have another name in the Gonstead lines of spinography, and it's very important to adjusting also. We use this line to adjusting occiput, for example. For in orthopedical spinography is called the gastric line. And this digastric line is a line draw connecting the right and the left digastric grooves, this area here. And then for orthopedical and clinical spinography, we can see for elevation of the odontoid tip that suggests basilar impression again, upward deformity of the skull base. This may occur secondary to congenital or acquired bone softening disorder like Paget's disease, fibrosdysplasia, and also rheumatoid arthritis and other clinical issues. Here is McGregor line. McGregor line is very, very similar with, you can see here, this Chamberlain line. The difference is Chamberlain is on the opisthyon, that is internal part of the posterior border, and the McGregor's line is in the lateral, external border of the magnum foramen. But the connection will be the same with the hard palate. And the reference it will be a little bit different. The other was 7, and this is 8 millimeters above the line in a man and 10 millimeters in women. And this reference is considering the tip of the odontoid process. And again, is the same. The evaluation and indication is the same. Elevation of the odontoid tip suggests basilar impression or upward deformity of the skull. This may occur secondary to congenital or acquired bone softening disorder. McGregor's method is considered the best method to assess the basilar impression. And here is McRae's line, is another line that we must consider. McRae's line is formed by opisthyon and also bastion. Remember that the opisthyon is the posterior border of the magnum foramen, and the bastion is the anterior border of magnum foramen. This line serves as the others I mentioned here before for basilar impression, and to see deformity of the skull surrounding the foramen magnum that may be found in rheumatoid arthritis, bone softening disorders that may be acquired or congenital, like Arnold-Chiari and Paget's disease and all this stuff. But there's another consideration for this line, the McRae's line, can be used to diagnose fracture also. For example, the tip of odontoid must be in the fourth of this line, and then you divide this line in 4 parts, and the tip of odontoid must be in the 4th part of this line. If it's not, maybe related with dislocation or fracture. And finally, we see these lines, the 2 lines that is more close to chiropractic now. Of course, we can use in orthopedics too, but it's more close to chiropractic spinography. And the first is FML. This FML is a line that is constructed in 2 points. This line links 2 points. One is in posterior margin of the surface of the magnum foramen, and the other is in the anterior part of the surface, the board of the verge of the magnum foramen also. And this APL is atlas plane line, and the atlas plane line is connected by 2 points. One is in the anterior arc of the atlas, and the other is in posterior arc of the atlas, maybe in this part of the atlas lamina, posterior lamina. and maybe in the middle, should be in the exact middle of this lamina. And the point will build this line, and these lines will be evaluated together, the relation of it, and we see if this will close like this or open like this. There's two possibilities for these lines. And then this is considered normal because it goes parallel in parallel. And we see in other slides, the continuity of this content to correlate with other lines. And this is the condylar transverse line and the atlas transverse line. They are also plane lines. This is atlas plane lines too, like this, but this is the atlas plane line in the profile in lateral view, and then just call atlas plane line, and this is called atlas transverse plane line. And this TCL is the same of the gastric line. It's the same thing of the gastric line. And this will build the correlation of alignment, lateral alignment between atlas and occiput. This X-ray is an open mouth. It's in Portuguese we say transoral X-ray. In English we say is more used open mouth X-ray. And then how we build the transverse atlas plane line. We have here a pencil. Here, pencil. We'll seek for the atlas, the massas, the mass of the atlas, like here. And this is the transverse of the atlas, transverse process of the atlas. And the dot will be done in the exactly in the point between and the below part of transverse process of the right and left, but in the intersection of the atlas mass and the transverse process. And this between the atlas masses, this is the mass, this is the mass, and this point will be between the inferior part of the transverse process and the mass. And this is transverse atlas line. And the other will be the same way we say in the gastric line. I mean the grooves on the major aspect of the mastoid process bilaterally. And this is the ADI. The ADI, this atlanto-dental interval, is dental atlanto interval is also ADI called, and there is composed. This interval is a space between the atlas and the axis, particularly in between the anterior arc, like this. I show you with the pen. Here, pen. This surface and this surface, this is the odontoid process. And of course, there is two intervals. This is the anterior and the posterior. The anterior here and the posterior. The anterior interval is this X interval, and the posterior interval will be this Y interval. The distance between the posterior part of odontoid and the posterior arc of the atlas, the surface, internal surface of the posterior arc of atlas. And this is the posterior atlantodental interval, yeah. And this is the anterior atlantodental interval. This is the anterior ADI. And then this is very useful to evaluate instability. I show you. When erase this here. And when the patient has we can order and dynamic X-ray, and this dynamic X-ray for evaluate ADI is very easy to do. You just ask the patients to make a flexion on the spine, and then when he flexionates spine, this interval tends to increase, and sometimes increase like a V. Okay? And when you ask the patients to extend, this space get bigger. That's what happened. And there is a limit for this. And this limit brings the diagnosis of atlantodental instability, atlantoaxial instability. That's why we had here. And this depends on the age of the patients. In children, there is a bigger reference. And this is here, should not exceed 3 millimeters. But we can questionate this information. In some books are 3.5, 3.5 millimeters for adults, and 5 millimeters in children's. And the flexion lateral projection, okay? Or what I say, the ADI may appear a V sharpened. In this case, when it's V, you can take the distance in the smaller part, not in the bigger part. And that's what I say about this behavior, mechanic behavior. When in the atlantodental interval, we ask the patient to do a dynamic X-ray, functional X-ray. When you ask the patients to make to be extended like this is extended, extension, and this is flexion. Yeah, and then in all the cases, even without disease, without the pathology, we will perceive the increase of atlantodental interval. The interval will be greater in all the cases. But when you have instability, the distance will be higher than normal. And then in the extension here, this kid has rheumatoid arthritis in juvenile onset. This kid have in extension 1 and 6 millimeters, and in a flexion he opened the gate, the interval to 7.2 millimeters. And what I say about the V is sometimes we have like this behavior like this in the joint. And then, okay, you just take the distance in the smaller part. And if you have behavior, a joint movement, joint pattern of movement, like here, like this, you must take the distance in the smaller part, not in the bigger part. This is the right way to do, okay? That's why you must see the V and take the distance in the smaller part. That's the right thing, the right way to do. And that is another two lines. We already know that push here the pen. We already know here the APL, Atlas Plane Line, that is built by the posterior lamina of the atlas, in the arc of the posterior arc of the atlas, and the dot in the anterior arc of the atlas, close to the anterior tubercle of the atlas, and this is APL. And there is other two lines now, two new lines. One is the odontoid line that becomes a line through 2 points. One if in the tip of the odontoid process, and the other here in part of tubercle of the axis, when he is the root of the odontoid on the body of the axis. And this line will be crossed by another that's called odontoid perpendicular line that will be 90 degrees forward to anterior. And this line with 90 degrees correlated to the odontoid line will give us information about the listing of the atlas, comparing the odontoid perpendicular line to the atlas plane line. And the normal would be more parallel situation between this OPL and this APL. And then the atlas can be listed anterior superiorly when this is open, and be listed AI when it's closed. These two lines are closed. Are the lines may converge like this. And if this converge like this, is considered AI. Okay, if it open, will be these two lines open, will be AS. Then we go next. This is also for atlas alignment, but this is open mouth X-ray. I guess we already talked about this, but there is a new that is atlas axis plane line. The axis plane line will be compared with the TAL, the transverse atlas line. This is built by the cross of the mesh and the transverse process of the atlas in the both sides, and this will be here in this part of this area of the axis that will be bilateral points between the lamina pedicle junctions bilaterally. Okay, and this will give us notion about superiority or inferiority of the atlas. And this is the way that we do now. We evaluate the rotational status of the atlas. And I'd like to say that it's important also to perceive this distance here. This distance is a type of atlantodental space also, but this is atlantodental space in AP view and transoral in the open mouth. And this is very interesting comparing with this sign here. In Portuguese, we say sinal da saliência is called in English over sign. Yes, it's called overhang sign. And then here is normal. And sometimes, if not, you can see this over sign here, overhang sign, and compare if these dislocations is like proportional, like with this interval too. Okay, and this may be some instability, and then we talk later about this. But what I would like to say is that the atlas can be evaluated in rotational status when you have the measure, of the lateral mass, of the atlas. And you take the measure here and here, and you compare these two measures of the right and left masses, atlas masses, and what would be the diagnosis when you have an more radiopaque and more bigger mass and this width. This, if this is bigger, should be this anterior. This is for anteriority of the atlas mass. Okay, of course, in some case there is anisomyely, and then with anisomyely with this area would be difficult, and then it's not rotation, it's a different bone in the patient. It may happen, but in this case you have signs of the adjustment will not go well, not have resolution, and something strange. And then when this happens, something not going fine in these patients, you must order a computerized tomography, and then you have the diagnosis of the malformation, the anisomyely. Okay, that's right. And then we go to the next slides. Is the overhand side. We talked before. Here is the overhand side, and this in the open mouth again show the two x-rays. With one is marked with the overhang sign, and the overhang here shows asymmetry with the interval, atlanto-odontoid interval in anterior view, and then that's what I say in the slide before. And other things I'd like to say that is very important to see the atlantodental space, not just anterior but also posterior. Sometimes you have something in the ligaments, and some volume or mass that may be a tumor, maybe like this situation that is called posterior ligament ossification, and also sometimes anterior ligament ossification. It is very important to see this interval before adjust the patient. Sometimes in this case the ligament is two, three vertebrae formed and ossificated, and if you adjust very strongly here, or maybe you can not adjust this patient because in a fracture, in case of a fracture of this ligament, you have a very big instability, and then is a good hint. Sometimes this will bring symptoms for the occlusion, and then is more common in patients with diabetes up to 50 years, and also patients that have rigid spine, cervical spine. When you palpate in a patient with 50 years old and diagnosed with diabetes, there's a high chances of to have this ligament ossification, posterior ligament ossification, and this is not good for adjustment. And then you must order an X-ray. If you have a rogue neck difficult to adjust, order an X-ray. To see is to know, and not see is just to guess. You must pay attention on it. And this is what we can find in the ligament, and yellow ligament sometimes, but this is not yellow ligament. This is the posterior ligament with dish, how we said before. And also pay attention in the posterior line in the vertebra, that when you find some disalignments, maybe also multiple levels of cervical instability, and then order and dynamic X-ray will be good for the patient. Dynamic X-ray is not just flexion and extension. For atlas, it's very good to see overhang signs. It would be very good to do inclination to the left, inclination to the right. It's very good to diagnose when you suspect instability. Don't forget about the sign, the very classical sign of instability is the sign of rust. And then when the patients wants to hold the head, to change the position, to go to the bed, to lay down. And this is a very alert, very red flag sign. And instability may be present. Instability is a translation, is a excess of motion, not only excess of motion, but this aberrant motion. Different of hypermobility, this is an increased motion. Instability is a wrong pattern of motion, not just increased motion. And the key of instability is the translation and excess of rotation and the risk in damage of vases and nervous structure. And then it's very important to do not manipulate this patient. Now we have a draw. This is very good to have practice. Is a draw of subluxation, and then we can. It's more easy for beginners. You can do the dots like transverse atlas plane line here and here, the two dots here, and then build a line here, and also take the measure of the masses of the atlas, see the intervals, look for overhang sign like this, a little bit of it, but this is compensated by this interval and this interval. You must see these patients and test for instability sometimes. And taking the masses, you see that this is anterior, and then you will also make a dot here in the digastric and build the digastric line to compare the atlas with the gastric line, atlas plane line with the gastric line, and also the place dots in the axis to make the transverse axis plane line to compare with the atlas plane line. That's not difficult to do. You must have just Übung macht den Meister. Must have practice on it. And this is the lateral view. If we talk about the atlas and the upper cervical, of course, just don't forget to do the dot here and the dot here for atlas, atlas plane line, and the dot here and here for the magnum foramen line here to compare the occiput with the atlas plane line and to compare this line here with the atlas, the axis line that will be not this line. Of course, we can have another line here, but we can compare the atlas. We must compare the atlas with the odontoid transverse line. How I said before, there is a line in the tip of odontoid process going down, and here another that is odontoid perpendicular line. And then when the odontoid perpendicular line is compared with atlas plane line, and this is higher, this is in AS. Its opening angle is AS, its closing angle is AI. Okay, and then we have here other evaluation of the lower spine, and we can place dots here and make a line between the dots and see the behavior of the lines, if it's converging or aloofing. Yeah, and you can have this information in the next slides. I will explain to you. And this also I will build dots and plane lines in all the vertebrae here. We should align and roll in 1/4 of the vertebral body down. Okay, in each vertebra. And this is how we list the spinography and the upper cervical is odontoid perpendicular line. This is transverse is magnum foramen line, and this is the odontoid perpendicular line, the odontoid line, the transverse plane line. This is the all of these vertebrae have disc plane lines that we make dots here, and roll one fourth of the vertebra, and do after the points, the dots, do one fourth, roll the roll one fourth, and do a trace that is a line that we compare this line with the others. We roll one quarter to do from the points to do these lines, and then you see, and this pattern here, we already explained it. We will compare for the atlas. We'll compare the atlas with the atlas plane line with odontoid perpendicular line, and to see the occiput, we'll compare the magnum foramen line with the atlas plane line to see if it is. We go further. The RPS or AS occiput, or AS or AI atlas, and on so weiter. Okay, and then in this situation we have a crossing of talking about lower spine. We see the C6 and the transverse. When we have the lateral view of X-ray, is the first thing to do is, well, first of all, we analyze, there's two analyses here. We analyze the lower spine and then the upper cervical, the lower cervical and the upper cervical. And it's two analyses. There's two analyses. There's a listing for occiput, for atlas, and also for lower cervical. But it's not possible to list any part of the cervical spine or any part of spine only using one view. X-ray plain film always requires two views, unless the hip, unless the pelvis. Yes, pelvis is the only one that we use only one view, the AP film. To do the listings, to diagnose the listing dysfunctions in X-ray, we must in cervical spine have two views, lateral view and AP view. And in AP view for lower spine, the first thing we have to do is make dots, dot the anterior corner of the vertebra, inferior and anterior corner of the vertebra, and posterior and inferior corner of the vertebra. In each vertebra, we dot all, yes, like we did here. And then after that, we will put here the roller, or chiropractic roller. Yes, we have two wheels, and we roll. That's why we roll the roll, roll the roll on the film to build a perpendicularly a trace that we go parallel to these dots, and then we build the traces, the lines backward until the end of the film, like this. And then we see what we see here. We see that the line of C6 is crossing the line of C7. Of course, all the lines in the normal spine, cervical spine in lateral view, should converge in a certain point. But C6 is converging pretty early, and the others will converge maybe in the long distance of the film. And C6 is converging very early. And this means that there is a P, and that's why we mark here C6P. And then, of course, it's P. You can adjust P, but it's not only these listings. Of course, we need to complete these listings. We need the AP view to complete these listings. And then we can perceive that these converge, this C6 and C7. C6 converge on C7, and C4 and C5, for example, diverge the line. And this means there is a compensation here because of the dysfunction of the vertebra below or the vertebrae below. Okay. And about the atlas, we conclude that we should compare the perpendicular odontoid line to the atlas plane line and see if it's diverging on the front and, of course, converging on the backward. And this makes an AS. It was because it was uh, diverging. If it was converging lines, it would be an AI. Of course, this is not a complete listing again, and the same with the occiput. The occiput, we compare the line of the atlas plane line, with the magnum foramen line, and in this case we see a conversion anteriorly, and this give us the diagnosis of posterior superior. If it was the against and diminishing this space is bigger here, and if it was diminished, would be an AS, and this line would be not converging. These lines would be diverging. Okay, and then that's why we mark here occiput PS, atlas, AS, and C6P posterior. And in this film, we can see in the lower cervical spine something a little bit different. We can see here C1, C2, C3, and the line of C3 is crossing the line of C4, and that's why we have a posterior here. On is the earliest is the earlier cross the conversion in the lines, and this is C3 is P. We consider C3P. Okay, and the others is like the same. These things we found here. And then when we see now lateral views, let's repeat it in an illustration that is more clear. This is a normal lined occiput, and the upper cervical is very okay. It's very balanced. And then foramen magnum line is traced. Atlas plane line is traced, and also odontoid perpendicular line is here traced 90 degrees with odontoid line. Odontoid line is built on the tip of the odontoid, and then after that we do odontoid perpendicular line. And then what we see here, this is not converging, neither diverging. Yes, and the same here. This is, of course, there is a limit that we can accept. For example, for our occiput, we have the odontoid line here, the continuity of the odontoid line, and we can observe here there's a tilt, maybe 5 degrees tilt, and it's okay. It's considered normal. Aligned. And then here is something different for occiput. We have here an diversion, anterior diversion of the atlas plane line comparing with the magnum foramen line. And this open here means that this AS. If this was diverging and closing this line, would be a PS, okay, and then they just come like this. And if it was occiput, PS would be the against. And it's the same on this X-ray. You can perceive, and maybe the cervical is with loss of curvature, the lower cervical that to permit this, to allow this. And this is PS X-ray, and PS X-ray is there is more space here, and then we have conversion of the lines. The magnum foramen line and the atlas plane line is converging anteriorly. Well, condyle transverse line. This is AP transversal, AP. Now, after having this situation that we have a PS and occiput, and maybe here is a line at atlas, but it was not, would be the first letter of the atlas. Okay, and after that we go to AP film, transversal film, and then we see the condyle transverse line. We would mark a point in each jugular mastoid notch of the occiput, and the atlas transverse line is the atlas plane transverse line. Mark a point at the lower aspect of the right and left lateral masses, where each transverse process of C1 joins its respectively lateral masses. This is axis flat line. Mark a point in each shadow of the C2 pedicles. And this is the open mouth, transoral. Here in Brazil we see transoral, but I don't know in Germany or other countries. And then it's more popular known as open mouth. And this open mouth we have here that is the same. This condyle transverse line is the same of the gastric line. It's almost the same. And here is the atlas transverse plane line, and you see there is a conversion here, and this is the axis flat line that we mark the points here on the pedicles, and we have the conditions to list both occiput completely and atlas completely, because you already first uh, we see the lateral view and discovered that it was a PS occiput, AS occiput, AI atlas, or AS atlas, how we say it. And then the occiput is subluxation, but all the ghosted analysis is due to the disc, and there is no disc here. And then we consider the capsule between the atlas and the occiput, and makes a protrusion, producing sometimes nerve pressure, sometimes inflammation, sometimes damage to the biomechanical movement, the motion, and sometimes pain due to the inflammation process, and not exactly compression of the nerve. Okay. And transversal, we have the condylar. Transversal is the open mouth. We have a condylar transverse line plus atlas transverse line. If diverse to laterally, we have a occipital PS LS, and transverse line of the atlas plus flat line of the axis. If diverge laterally, we have a atlas ASR, something like that. Measure the lateral masses of the atlas horizontally, and the larger mass suggests anteriorly. The atlas is A. Again, yes. If it's small, the mass is small. Is the atlas is in the side P. But first of all, we have to see if it is atlas AS or AI, and then it's mandatory to see the lateral view, the lateral radiograph first. Whenever on the lateral mass of the atlas is the condyle of the output is posterior. Okay? When the atlas is in the one side, the output is in the other. And like this, we have the lower cervical spine here. And then we can see the after the tect is the same patient we have here. Remember this image, this illustration, this is C6 that was considered P. And after seeing this, we now see the AP view. And then we can see what's happening with the P, if it is on the right or on the left. And we should consider the spinal process, but there is a lot of anisomely of the bones in especially in spinal process, and then we consider the this part, the pedicle, and this is more accurate to see where the vertebra is rotated. And I mean, the reference is a spinal process, but sometimes we must use the pedicles because less degree of anisomyely. It's anisomyely means um, congenital change in the bones. Maybe it's not a disease. It's just because all the peoples are not the same. Okay, are different. And this is also PRI dash L. And then we discover what is P, the vertebra is P, and after we discover the side, and then what side is converging line, and then this inferior, if the spinals is to the right, and the wedging of the disc is inferior, that side is inferior. Okay, that's the rule. And then listing line, baseline, diverge to the side of the opening wedge. Yeah. Mark a point in the center of the spinal process of the vertebra that is P, and compare the distance with the unsedate process of the side with a shorter distance. Is the side of rotation. C6 PRI-L. Note, repeat these steps with all P vertebra found on the lateral cervical X-ray. Now we have the odontoid line. We build the odontoid line first, with this points on the tip of the odontoid process, and almost in the end of odontoid process. And after we draw a transverse line, and this line will be in 90 degrees in this area of a tubercle here. And then this line will be used to list atlas, that the vertebra above, the first vertebra, the upper vertebra. And then we have the building of the atlas plane line. This atlas plane line is in the tubercle, anterior tubercle, interior arc of the atlas, and posterior arc of the atlas. It's easy to build this line. And then we compare the odontoid perpendicular line with the atlas plane line. If it's going to conversion, is AI. It's going to diversion, is AS. You must know that the first direction of the atlas misalignment is anterior, first. Why is not posterior? It's against the other vertebrae because there's an anatomic over here that is the odontoid process. And then if you have the odontoid process here, no possibility to go backwards. And then the subluxation is always anterior. And then when we see the letters ASR, means that it's not atlas, it's anterior superior to the right. Because the first listing is A. And I mean, how we build the listing. A, S, R. A, I, left. Or A, I, right. Or a more complex listing. A, S, R, P. A, I, L, A. And this means that the solution of the atlas, I'll change here. The solution of the atlas is, the first solution is A. And then after we have a possibility to be AS or AI. If it is diverging line here with odontoid perpendicular line, this line is diverging, will be, and diverging will be AS. It was converging, it will be an AI. And then these two letters here, I cannot see, I cannot diagnose with the lateral view. I need, of course, the AP view, okay, to do the other letters. And this this is the AI, and this is the AS. Yeah, this is converging lines, and this is diverging lines. This is the gastric. The gastric line is same or name of transverse condyle line is the same thing, and it's also used to observe the basilar impression. Like, what is basilar impression? Is it disease? Is it no? It's a morphological change, acquired morphological change, due to the softening, bone softening, in, of course, many disease like Marfan syndrome. Found this in Arnold Chiari. You found this in the rheumatoid arthritis in some cases. And then, if the odontoid is crossing this line, it's a disease. Must pay attention on it. But it's also useful to diagnose listings. And then first we had this evaluation, or this evaluation, and also for occiput, you have here, or these for occiput. And then we have a possibility for PS according with these lines, or AS because of this behavior of the lines. And now we have a possibility to complete the listing of the occiput and the atlas, because uh, we see we see before the lateral view, and then we see the AP view and upper mouth view, and then we can observe laterally if the other lines are converging or diverging, and evaluate also the atlas masses, the widths of the atlas masses, and complete the listings, considering also here the axis plane line. Like this example. And for this example, you see there's diversion of lines here, the gastric transverse condyle line with the atlas transverse plane line, and there is not a diversion here on the axis transverse atlas plane transverse plane line with the axis transverse plane line. Okay, not big diversion here, but there is a very big diversion here. Understand? And this means there is a change in the occiput in one side. Of course, if you see just this image, it's not possible to diagnose. But if this is PS, if this is PS, this occiput is PS, and we got this conclusion in the lateral view, it's easy to know what is happening now because it's PS, and then you repeat the listing, the letter PS. What side is it is on the right, because we are looking the X-ray different in chiropractic, in constant chiropractic. We go for the backwards, the X-ray from backwards. And for example, if there's no rotation on the atlas, no rotation status, the masses would be equal. It's more easy to understand like this. Let's pretend it's no different within the masses. And I saw this in the lateral view. It was PS. And output was PS in lateral view. The lines were diverging posteriorly. And then I see here now and situation that transverse condyle line and the transverse atlas transverse plane line is opening here, means there is a superiority on the right. And then I will build the listing of output like PS dash right RS PSRS. That's why it was a PS on X-ray on the lateral, and then lateral view would be like this PS, because there is an open space here. And then when I see the AP view, I can perceive that on the right side it was up. It was a space here, and then in this space on the right means that's superior. And then I say is PSRS. If we have a PSRS, we can have also a possibility of rotation. We can have two possibilities here. It may be just PSRS, and then the adjustment is very easy. But also can be PSRS. I repeat the letter, right? P, because if there is also another dysfunction that is rotation status, will be RP, and it was PSRS RA. I repeat the letter of the laterality again and say that is a rotation to anterior side. And then there is a two possibility for this listing. Okay, and the same will be with the atlas. It's very similar. And what give us the basis for what give the basis for the rotation, the lateral mass of the atlas. Is one thing that we have to do, and then we must to take the measure of these masses, and you perceive this is P, because it's the small distance here, and then this P, and this is A. And if this is A, and this may be the against of this, okay? If one is A, the other is P, okay? For the rotational status. And then we have here an ASRS. Why this is AS? Why this is AS? Is AS because when I see first this patients, he was I build in the lateral view. I build a line on the magnum foramen and then a line in here in the atlas. That was atlas plain line, and these uh, um, behave like an aperture here, um, the version of the lines, and this is the information to give AS letters built here for occiput. Yeah. And then after seeing the lateral view and know that is AS, listen, if it is AS, now I see the AP view and see what side is going up because I already know an information and then I go to the other. And then I build another two letters, right super, ASRS. That's how I build this listing. And this is ASRSRP, of course. RA, sorry, array. And then how I know it's array? Because there is a rotational status of the atlas, and this is atlas A on the side. Yes, but I'm seeing the last letter of the atlas. And then in this illustration, the ASRS are not A, are P. Why it is? Because look at the atlas, the mass of the atlas. Take a pen here. This width is bigger than this width. And then we consider this A. And if this is A, this would be P, of course, because there must be in balance one to the other to compensate. And then it's very important to know that this A is not the first letter of the listing of the atlas, but the last letter. And then doesn't mean that this is an AS or AI. And this is ASR, A or AI, R, A, R, A. Okay, this letter is not this letter. This letter is the last letter. Okay, and this information is very important because in the same side occiput will be posterior. If this will be neutral, erase it. If this will be, if this would be neutral, not P, and then this distance will be the same if it was the same, and then is I would not consider P here, would be just like this ASRS, and I will ignore this possibility. I only consider this possibility when there is a last letter of the atlas. I mean last letter, rotational status of subluxation in the atlas. Remember, this is the last letter. And this is all the occiput listings, all that we have. We have here the AS and PS listings. And this is some examples. We have an open space here. And then there is a superiority here. And this is PSRS. And the other, ASLS, we have an open space here and superiority on the left. It's easy to adjust this. And then here we have a crossing line here is also put PSLS because there is a change on the mass of the atlas. It's not only superiority, but there's a compensation due to the lateral mass of the atlas here. There are different width, and same like here, but this is the not A, it's P, okay, and this is PSLSLP. How you see here, open space, okay. And then about the cervical, lower cervical again. We already talked about this, but just to review, all the lines tends to converge. A better spine would be that spine that converge more harmonically, and in the very end of the film. But sometimes one lines converge, they converge early, and this is what we consider P. And this is a normal view. You see, we have the view of all pedicles. We have to consider all pedicles because it's more, how can I say, it's more reliable. See the pedicles, not only the spinal process. And this is the normal again, lateral view. And this is, you see, a diminish in the angle. There should be an angle here, and the lines should be slightly converging. And this is not so good also because there is maybe a compensation here. And that's what we see here. Early conversion of the lines means that these vertebrae should be considered as a P. And then we say this is P. And this is an image. I'll show you with the pen here. And then we have C6 posterior. And this image, this X-ray in lateral view show us how the subluxation here, you see the C6 is crossing the C7 line here, converging here. How the subluxation is related to degenerative change. You can see here the posteriority of the disc, and there is a diminished space here and sclerotic margins here also. And this is a correlation of subluxation and joint health or degenerative change. That's very important to understand that chiropractic can help give motion, mobility, and decompress the spine. And when this happens, we'll have less biomechanical stress, and less biomechanical stress brings more health to the joints. And this is a subluxation of C6, showing the compensation. See compensation here, compensations. These compensations of how it's written here is to keep the head more neutral, and this is to spend less energy. This compensations helps to save energy. Okay, it's very important because with no compensations, more muscle stress, more imbalance, and this give more spent of energy. And this is L5 posteriority, and this is 1, 2, 3, 4, 5, 6, 7 to T1, and this is 7 is posterior. This is P. Okay. And now again to the open mouth. Let's see something more about the atlas listings. Just to remember you, this is the transverse plane line of the atlas. This is the axis plane line. And we have these misalignments like ASR. ASR, you must understand that there's no disc here, but the capsule can swivel and protrude, making the atlas go up. And then this atlas will be AS, because in the lateral view the atlas was like this, considering the axis transverse plane line. And then how we saw these in the lateral view, and then in the AP view we see what side was up. What is up? Because you already saw in the lateral view that it was AS. And then you look at the superior, and you see the superior is on the right. And then the right goes to AS to bring ASR. Okay, ASR. But why don't have another letter? Because when we take the measure of the width of the atlas masses, is normal. There is no difference. And then the opacity also, the opacity is equal. And then there is no anterior and or posterior atlas and rotational status for the last letter. Okay. This is ASRA. This is a more radio opacity also, and the width is bigger. And this is ASRP. The width is smaller and also less opaque, more translucent. And why it's bigger or smaller mass of the atlas? Because rotational, this is normal, no rotation here. But when there is rotation, the shadow of the masses become bigger when rotated anteriorly and smaller when rotated posteriorly. And this is P and this is A, and more radio opaque, and this is more radiolucent, like this. Easy to explain with this image. And this is an ASLA. And these are then the other types of listings of atlas. ASRP, look at this, the posteriority here. ASR, no rotation status. Here, ASRA, the atlas is rotated anteriorly. And this is all the listings of the atlas. And this is ASL. Look at this. The atlas plane line compared with the axis transverse plane line. Here, it's ASL. And when we see the AP that is on the left is up, and then is ASL. And this is AR. In the case of A-R, there is a abnormality here in the output, But we are not talking about occiput, we are talking about a atlas. And then we must see this line and this line. And you see this is parallel. These two lines are parallel. And then it's okay. Then there is no superiority and inferiority of the atlas. But we have something different that is the slip. There is a little bit of slip on the right. And then we consider A dash R. ASRS, look at the anteriority on the right of the atlas. And this patient was with anatomic deficiency of the right leg. But this is just clinical information for us. It's not shown on this picture because it would be another view. It's not a view of the cervical, it's a view of scanometry. And Atlas list ESLP, same thing. And this is different. This is quite different. This is ALA. This listing ALA, you can see that you can see here the odontoid perpendicular line and the atlas plane is normal, but there is no superiority and no inferiority, but there is a rotational status on the left. And this rotational status without superiority and inferiority we call dash LA because it's anterior. And when it's anterior is LA, okay? Left anterior. And that is why we don't have superiority, so no superiority and no inferiority. Okay. And this is the difference of ASLA, for example. Look at this. You have here we have superiority here. We have here AS here. But in the previews, no, we don't have it. This is parallel. The lines are not converging and not diverging. Here the lines is diverging and converging in the back, diverging on the front, and this is AS. And then we see that there is a left superiority and also anteriority because of the atlas. And then all the kinesiopathology and X-ray and the listings are respect the same way to think. You must have the order, the sequence, seeing first the lateral view and then use the AP view in the cervical spine, thoracic spine, lumbar spine mainly. X-ray plain film always requires two views. This is a very important law you must respect when you're analyzing pathologies and when you exclude conditions that are not indicated for chiropractic treatment and high velocity low amplitude techniques. And you must understand that motion palpation and inspection and scoping the patient, visualization the patient is very important too. And if you see something wrong in X-ray, like that you suspect a subluxation, doesn't mean that this is subluxated. Doesn't mean because you have also distortion on the spine. You have another models of subluxation that you can think sometimes. And if you have a P on X-ray, if there is mobility in the physical examination, don't need to go for X-ray. You must go see for the patient. is very important. The motion palpation is predominant. The movement evaluation is most important in the hierarchy. Okay, you must understand that. And when you have a suspect of subluxation due to the X-ray, this subluxation must have hypomobility. There's no subluxation without hypomobility. Okay, but sometimes hypomobility is not the subluxation because it is a compensation, and then you can use the X-ray to see something like that. Okay, and I'm very thank you if you hear all this stuff more than 2 hours, and this is my small contribution for you in Greece and Europe. Okay, thank you.